want to welcome all of you today to this, our aging conference. And this year, it's Take a Deep Breath. So guess what we're going to be focusing on? Our lungs and how we breathe, right? This is, I was told, our 7th aging conference. I can't believe it that when we started in 2010 and we've, come this far. And I hope, can you show me a hand if you've been to any of the others? Thank you. Have you enjoyed it? This is a worthwhile thing to continue, don't you think? Well, I think so too. Thank you. And today, I want you to help me welcome Dr. Nambiar. He is a fascinating physician to talk to. He was born and raised in New Jersey and got his first medical training in Rutgers, and then he went on to get his internal medicine residency and training in pulmonology at the University of Michigan in Ann Arbor, and then he did fellowships after that. And the UT Health Science Center in San Antonio was very fortunate to get him to join us in 2010. At the present time, he is the director of the Interstitial Lung Disease and Pulmonary Fibrosis Center in San Antonio. And he was just telling me this morning that he is the only one in that whole region that does that kind of work. So you can believe me how busy he is. So we want to thank him for taking the time to come in to join us today. So with all ado, please help me welcome Dr. Nambiar.
Good morning, everyone. How's everyone doing? I missed the Wii sessions, but I heard that it was a hit. So, and this whole conference, I'm really honored to have been invited. This is my, I believe, 3rd time in Laredo. I've been a speaker at the Updated Medicine Conference by AHEC in October, and so it's a real honor of mine to have been invited to the Aging Conference. So the title of my talk is Interstitial Lung Disease, an often unrecognized killer. And some of my disclosures, as you can see, I've worked with a number of different drug companies, primarily research and also some consulting. And so I wanted just to make sure to acknowledge this conference because I think it's a wonderful thing. I'm a very big advocate in terms of getting word out to the community and outreach to the community, and really, as we just talked about briefly before, about engaging the community as in a team effort, really to help everyone feel better. And this, what we're going to talk about is hopefully, breathe better, and the goal is to live better. And so I wanted to start out by just asking and posing this kind of scenario. Imagine you or a loved one of yours developed an unexplained shortness of breath or chronic cough. It's amazing with Google that you can get these pictures pretty quickly. So I'm a big fan of pictures more than words because I think they tell the story better. So you might think this reason when these symptoms are happening for the shortness of breath, and this is if there's some on this list that I don't have here, please let me know. But the most common things are I'm just getting older. I'm out of shape. I think for almost every one of us, that could be an issue. For me especially. I've gained some weight, maybe over the holidays. So in the beginning of the year, then maybe that's the reason for the shortness of breath. Or bronchitis. I put it in quotes because it's something that everybody knows about bronchitis. You're coughing, maybe you bring up a little bit of phlegm or not. How about allergies? I know in San Antonio, allergies right now are a big problem. This past clinic of mine, I think a near majority of patients I had who have lung disease also are dealing with allergy problems. Or not sure what it is, but hey, it's probably nothing serious. And so I put this comment, we, and I probably emphasize maybe men and myself in particular, we often ignore symptoms until our loved ones, and I kind of say our wives, I'm married, so I know that it's my wife who's probably going to say, you should probably get that checked out. Or other partners finally push or force us to finally go to the doctor and get things looked at. So you go to the primary care doctor's office, or your loved one does, and this is a generic picture of a doctor. Common, you might hear this in medicine, we use this a lot. Common diseases occur commonly. Okay, so we're not looking for rare diseases when you present with certain symptoms like shortness of breath or cough. We're thinking about asthma, we're thinking about acute bronchitis, or we're thinking about chronic obstructive pulmonary disease, which I'm sure a lot of you have heard of, emphysema or chronic bronchitis. And then there's heart disease. So statistically, on average, 50% of our population have at least one risk factor for having heart disease. And so it's a very common problem. So why look for rare diseases when these statistically are just going to be more common? So then the doc might have this kind of look, perhaps, after you tell them about the symptoms. I'm not sure what's going on, but why don't we try some inhalers? Why don't we try some antibiotics, maybe? Or how about prednisone? I'm not sure if you've all heard of prednisone, a steroid. It's a very potent, strong anti-inflammation drug. Let's just see what happens and see if you get better. And if you get better, whatever it was, it's probably one of those things, like infection or asthma. If you don't get better, then we have to kind of consider something else. So let's say you get an x-ray because maybe you didn't get better or your loved one didn't get better. So we get this x-ray, and not going to try to teach you all how to read this x-ray, but I can just tell you that this is normal. This is actually a normal looking x-ray. But maybe you get a report that says some increased interstitial markings, and then some docs might look at that and say, even the radiologist reading it might say that's probably nothing significant, and the bottom line, no acute process. And if the x-rays actually can be normal if you have early interstitial lung disease. It's in the later advanced stages where the x-ray starts to look like this, and it really becomes something noticeable. But it's the early stages that I want to highlight, which the x-rays can be normal. So the symptoms may persist, and now what? So I just, as a commentary, so doctors are human, in case anyone didn't know, but I have to remind my patients that as humans we make mistakes, and that's something that we often try our hardest not to, but it can happen, sometimes does. But as a patient, and all of you all in here, and all of us, really, when you have your doctor, you have to have a relationship where you feel comfortable, that you can talk to someone easily and unhindered. And I think trust is probably the most important thing. You have to trust, understanding that mistakes can happen, things can be overlooked, but if you can give someone your trust and you feel that they are looking after you, looking out for you, they're going to do the best job possible. And if there's any concern at this point with the shortness of breath and the cough symptoms, you really need to see a specialist. Okay? And I would actually recommend starting locally, of course, with your community pulmonologist. And at this point, if you see a community pulmonologist, they might look at that report, the x-ray report, and say this could be something called interstitial lung disease. And that's going to be the focus of the talk. So what is interstitial lung disease? So basically, the job of our lungs is to bring in oxygen from the air, get it through our airways and into the lung, exchange, the oxygen gets exchanged over the small alveolar sacs, and then the carbon dioxide comes back. And so that oxygen gets in the blood and then carries forward to the tissues. Interstitial lung disease is basically inflammation and or scarring or fibrosis. So it can be a combination of both, which basically in that space where the oxygen is trying to get over to the blood and carbon dioxide is trying to get back. And when that scarring or inflammation occur, then it becomes a lot harder for oxygen to get through. And so you're not able to get as much oxygen as you need into the blood. Because of that changes in the interstitium, the lungs start to get more stiff and they actually shrink, they get smaller. And then it becomes harder for people to take deep breaths. Actually, patients are really struggling sometimes, depending on the stage, with breathing. And coughing occurs. And then ultimately, over time, if this progresses, we don't do something to try to stop it or reverse it, then respiratory failure and death can happen. So this is a slide that I use for when I talk to other doctors, other pulmonologists around the country. This is the classification we use in our medical literature about how do we look at interstitial lung diseases. And so it's a very busy slide, and that's for purpose. It's to show you how complex this family of diseases are. And so just focusing on really what are the known causes and unknown causes. And that's actually how I explain it to patients who have interstitial lung disease. The different known causes are autoimmune diseases, things like rheumatoid arthritis or scleroderma. And I put some other kind of terms for autoimmune diseases here. Exposure is actually a pretty big thing. I tell patients this too, that there's really 3 major organs of the body that are always exposed to the environment. Our skin, which is the largest organ of the entire body, our eyes, and our lungs. And so for that reason, anything that we breathe in has a potential to cause injury to our lungs. Now, when I ask patients, so what have you been breathing in lately? That if a doctor asked me that question, I said, I mean, I don't know. I haven't, I'm doing what I'm going from one place to another, office and this. So it's very difficult to really know what we're breathing in all the time. And so it's really a patient who can recall clearly that they've been exposed to something, they know that some symptoms have started around that time, then those exposures become important. But I want to highlight things like at work. So being, obviously, workers, especially with brake lining or in the shipyards, asbestos is something that has in the past been obviously a major problem. Now we know more about it, so it's less. Silica in different occupations can be a problem. I have a patient who's a sandblaster. He does sandblasting in the inner part of a nuclear kind of facility, container. And so he was exposed to a lot of silica, and then that can cause your lung disease. It's very easy to ignore what's going on at home. I ask these questions about mold at home, any water damage that's happened where there could be mold. And mold is something that is extremely difficult sometimes to know if you have a problem with that or not. Bird feathers. People wonder about why I put bird feathers up there. It's actually a very common cause of interstitial lung disease. There's a protein on bird feathers that you can inhale. Once it gets in your lung, it can actually cause inflammation, and then that can lead to scarring of the lung. Humidifiers, hobbies, woodworking, actually. Wood dust and metal dust actually can incite inflammation and injury to the lung and start a process of interstitial lung disease. So we go through this list when I'm seeing a patient in the clinic to try to identify as best as possible if there's a cause to the lung disease or not. And if I cannot identify a cause, we call that idiopathic, and that's the Greek word for, which basically means no known cause that can be identified. And the most common type of idiopathic interstitial lung disease is something called IPF, idiopathic pulmonary fibrosis. And so when I look at this, we go back to the classification, I really break it down and try to simplify it as to not IPF and IPF. And I'm going to tell you why, because, and it's the most common and the most lethal of all the different interstitial lung diseases. So this is a slide just showing you what the 5-year mortality rates are for IPF compared to cancers. And IPF carries a prognosis that's worse than many common cancers, other than really advanced lung cancer. And so it is a terrible disease with a very poor prognosis. How common is that? So I just showed you a slide showing how bad it is. How common is it? And it's considered to be relatively uncommon. And I put uncommon in quotes because I'm going to show you why. But asthma, the statistics show we have about 18 million people in the United States have asthma. 15 million have COPD. And 5 million have heart failure. And I mention this up front because when the symptoms of shortness of breath and cough come up, you should think about these. Statistically, these are more common. and IPF is about 150,000, you're looking at 1% of the number of people who have COPD. But is ILD, is interstitial lung disease and IPF truly uncommon? So in fact, this is actually just some recent papers done that have been published showing that in a general population of patients, and we're not talking about folks with known lung disease, we're talking about general population of people. They did CT scans and they found that 7% of those people had interstitial lung abnormalities, or ILA, which basically means subclinical interstitial lung disease, meaning the patients had not yet been diagnosed and they didn't have yet symptoms. This was just purely looking at the scans. 7%, that doesn't sound like a whole lot, but is it? So 7% of our population in the United States, 322 million people, is 22.5 million people. So let's put that back into the slide, the last slide I had, and now we're talking about, and I put question mark because it's not been confirmed, it's not been defined, we're just kind of extrapolating. But if that is true, then you could argue that interstitial lung abnormalities and possibly early ILD is actually very common and maybe even more common than some of the other common diseases of the lung. So what happens here exactly? So just looking at a normal, this is actually a nice red looking brand new Tesla car, and then you can see a CT scan that shows nice and clean, normal, healthy lung. And with lung injury, then you get a car accident. You get a little fender bender and a little busted up, but it's potentially reversible. Take this to the shop and the body repair guy will take care of that. It might cost you an arm and a leg perhaps, but it'll at least get fixed. And so there's some diseases I think about in the lung, like infections that I can treat. I can reverse whatever's going on. There's other diseases there, I'm not going to go into detail, but that are treatable, that are reversible. A lot of interstitial lung diseases, and IPF in particular, are irreversible damage to the lung. The lung has it's a complete car wreck. You can take that to the body shop guy, and the body shop guy is like, sorry, can't help you there. You're going to have to get a new car. And that's what we're talking about when we talk about lung transplant. It's getting a new lung. This is severe IPF, idiopathic pulmonary fibrosis here, with all the scarring of the lung that's happened. And that's beyond, in 2016, we don't have a way to reverse that. And right now, we're actually still trying to get ways to stop it from getting worse. So idiopathic pulmonary fibrosis is actually, like I said, the most deadly of all the ILDs. It's irreversible. This is a scarred lung, and you can see this is actually an early disease. This is late disease. Look at how scarred the lung is compared to this one. I said it's a specific type of ILD. Idiopathic means unknown cause, and it gets worse. It only gets worse over time. Like I said, we don't have a way to stop it. And the other very tricky thing is that it's unpredictable. And we don't know yet how to predict. We know everyone gets worse, but there's some folks who get a lot worse quicker and as compared to others. And there's no cure or therapy right now that can stabilize the disease. So why is this happening? Why is this fibrosis, why is this scarring continuing to happen? We think it starts, and this is a complex slide, but this is actually a picture, a zoomed in a cartoon, we call it, of a lung sac and the different things that are happening. And usually it starts with some kind of injury. And I mentioned some of the exposures, and it can be a variety of different injuries. We don't know, there's no one injury. It could be some things you breathe in here, some things you breathe in there, some things you are doing at work. And then on top of it, you're predisposed, you're susceptible to get more injuries. So those repeated injuries lead to an abnormal repair response. It's almost like you cut your hand or your finger, it bleeds, the bleeding stops, and then a scar forms, but in the lung, in IPF, it keeps forming. More and more scar forms, and the lungs get stiffer and stiffer, and that's that progressive fibrosis. Risk factors, I mean, everyone wants to know what is the cause. And like I said, we can't really pinpoint a specific cause, but smoking is a big risk factor. And, I think we're making a lot of headway in our society about encouraging quitting smoking, or just not even starting to smoke, which is probably the best way to do it. Environmental pollutants. Here in the United States, we do a good job of at least trying to restrict pollution and other kind of things that we're breathing in either at work or outside. Other countries are still dealing with this. Third world countries, where it's a big problem. In fact, in other countries, COPD, which we think is a smoking-related lung disease, they have a big problem with pollutants and things that, like biomass fuels that they're using that can cause COPD over there, as well as smoking. Infections, there's some studies that show maybe infections are one of those things that start the process. Reflux disease, this is a big thing, and we all, whether you want to admit it or not, it's true that we all microaspirate. We all have some degree of reflux, but it's usually at a very small level, and it's usually not bothersome. There's some folks, though, that have actually more symptoms, more reflux, and that can actually cause injury to the lung and set off the process of inflammation and scarring. And then genetics. This is a growing area. In almost every disease that we know of, this is a growing area of interest, where we're trying to identify people who are very high risk to develop certain diseases, and genetics is becoming one of those things of identifying different problems in the code, different mutations and things that have happened. So when should we think about ILD or IPF? And so really any adult who has unexplained shortness of breath, unexplained chronic dry cough, so as opposed to acute cough when you have a cold or flu, that's something different. That really should go away in a few weeks, but it shouldn't last for months. And that's what I'm talking about. A chronic dry cough is going for months. Shortness of breath, just with exercise. One of my favorite cases is a 85-year-old who is a very active guy. He was walking 2 miles a day, and then he told his doctors about 6 months before he saw me that he wasn't able to do that anymore. He was doing 1 mile a day, but that change happened within about 6 months. And a lot of people just kind of ignored it, dismissed it. And it was only later that we found out that he had actually interstitial lung disease. So a decrease in your exercise capacity in a short period of time, relatively short period of time, you cannot just attribute it to age or weight gain or this and the other. You have to maybe consider something more serious. And I think family history, I told you about the genetics, that if there's a family history of somebody with interstitial lung disease or pulmonary fibrosis, that can predispose you or another loved one to developing the same disease. So a delay in diagnosis can lead to a delay in referring to a center that specializes in those diseases. And so recognizing that, still we think it's uncommon compared to other diseases. The Pulmonary Fibrosis Foundation, which is the largest patient advocacy group in the world, for patients with ILD and IPF, have created a network of centers all around the United States that specialize in ILD. And so these are centers of excellence, and it started in 2013. At that time, only 9 sites in the country were recognized. And the strength is really in patient care, so delivering the best care possible, education and outreach, like these kind of events where we're trying to get the community engaged, and research. These are all the primary strengths of these centers. And in 2015, this is the map of all the centers in the country that were recognized. And we were recognized last year as a center of excellence here in South Texas, and the only one and one of 3 in the state of Texas, which is, as all of you know, is a very large state. Thank you. So essential tools. So what are the tools that we need? Now we know how bad it is. It's a severe problem. We want to get a diagnosis early to try to get right treatment. How do you diagnose this? So you have to do a very thorough history. I spend usually on average at least 45 minutes to an hour talking to the patients about what's going on with their lungs. But then I have to go through all of the exposure. What have you been exposed to? What's your family history like? All those different things. That takes time. My nurses in my clinic aren't here, but they'll tell you that they're not happy with me because they have to tell the other patients that he's behind. And I try to hopefully get the new patients in early so that my follow-up patients who like me, I think, for the most part, I can tell them I apologize, but I did the same thing for you when you came to see me. And it's something that has to be done. Breathing tests have to be done. Blood tests have to be done. X-rays have to be done. And we might have to do some other procedures in order to get the right diagnosis. And so these are some pictures of the breathing tests and the CT scan. And ultimately we might need, hopefully I don't, but if I can't get a diagnosis with all the other tests, sometimes we have to do a biopsy of the lung. We have to get a piece of the lung tissue and look at under a microscope. That has risk to it, so we don't want to do that on everyone. And ultimately there's something called a multidisciplinary discussion. This is such a challenging disease to diagnose that in order for me to tell a patient that you have a disease that's worse than other common cancers that I don't have a good treatment for, I want to get everybody that I can involved. Because we talked about it earlier, all these things, complex things, it's a team effort. You need help from everybody together. And so I get other lung doctors there, I get a radiologist there, I get a pathologist specialist there. I entice them with a nice lunch to get them out there. Sometimes you have to do some incentives, but they're there and we're all working together to figure out what's going on. So I said diagnosis can be very challenging. In my own experience, and actually they've done surveys for patients, they've asked patients, how often were you misdiagnosed? And in my experience, 50%, half of patients who get referred actually are diagnosed with, who are told they have IPF, don't. They actually have some other kind of interstitial lung disease that actually may be more treatable and maybe even reversible. And why is that? Why? And some of the reasons I think are the time. So in order to talk to a patient and to get all the information you need, it takes time. There's no way around it. I have not yet figured out a faster way other than giving someone a questionnaire to maybe help them think about things ahead of time to bring to me. There's no other way to figure out what's going on with someone's symptoms, why they're having it, other than talking to them. And that's why I think computers are fantastic and robots are great, but I just don't see them taking the place of talking to human in terms of figuring out what's going on. Physical examination, extremely important to listen to someone's lungs and look at their other characteristics. Blood testing. So oftentimes patients are just not getting all the tests they need, all the blood tests they need. And this again is where a specialized center comes in handy. And the CT scan. There's a lot of types of CTs that we can get, but in order to diagnose interstitial lung disease, we need a very particular, special type of CT scan that gives us the best quality images to make the diagnosis right. But I think also not only get the right diagnosis, but also avoid subjecting somebody to a biopsy of the lung. So if you get a CT scan and they say, we need a biopsy of the lung, I would say you should get a second opinion before you go forward, because a biopsy of the lung is a surgery, and that could cause a lot of problems. And if we find out later that you actually didn't need it, we could have saved a lot of those issues. So multidisciplinary approach to diagnosis and treatment. I Googled pulmonologist, and And then I thought to myself, wait a second. I think I have a picture of myself I can put there. Radiologist. Next time I'm going to get my radiologist picture up there. Pathologist. And then sometimes we need a rheumatologist who specializes in autoimmune diseases. This is actually our transplant pulmonologist. I decided I'm going to put Dr. Angel there, and then that's actually our surgeon, Dr. Giarman. So I need everybody's help. It's a team effort. I need everyone's help, and this is something that in a community center, smaller center, and even a relatively large center, you might not have all these folks specializing in interstitial lung disease. And that's why the PFF, Pulmonary Fibrosis Foundation, has created those centers of excellence. So natural course of the disease, it depends on the type of interstitial lung disease. Try to remember the picture of those cars that I had about getting a fender bender or getting into a car wreck. There's some that can be reversed. We can treat that. We just have to get, hopefully early, get the diagnosis early enough, initiate the right treatment plan. But there are some that may only get worse. And IPF in 2016, because I'm a glass is half full kind of guy, I'm an optimist, and I hope I can change this in the future. But in 2016, IPF only gets worse, even with available therapies that we have, I'm going to talk about. Most of the time it's slowly, some of the time it can be very quick. And if it's irreversible, scarring of the lung is irreversible, for some patients, not everybody, the younger you are, the healthier you are, the less other medical problems you have. If you have a irreversible lung disease, lung transplant is something that can be life-saving, and I know firsthand that it's a wonderful thing. It's though there's other problems though with that in terms of anti-rejection medications, infections, and other problems, but you're exchanging one horrible, horrible problem for another problem that can be, we do a good job pretty much of managing. So this is actually the slide taken directly from the International Society of Heart and Lung Transplant. On the x-axis is the years. So we're going from the 1990 here all the way on the left and we're going all the way to 2013. And on the y-axis is the number of transplants being done. And if you look at the slide in yellow, I'm going to focus you on two colors, yellow and green. And if you start all the way over here on the left, yellow and green, those are the number of transplants being done, yellow for IPF and green for COPD. And if you recall, IPF and COPD, IPF is 1% of the COPD cases. But in this, back in the 90s, it was actually pretty close as the cause, the reason for the transplants that had to happen. And you can see that COPD started to get more than IPF in the numbers of transplants, but now IPF and COPD are really the two most common indications, and by all accounts, most people think actually IPF will probably be the number one reason that we do lung transplants for. And this is a survival curve basically showing that, so IPF is a disease, I said a 5-year mortality of 70%. It's actually about 3.8 years on average people live after they get diagnosed. Lung transplant, we think is about 4.7 years on average. Now that's an average. Everybody, I like to say, and people say, is not average. You don't fit an average, but statistically, that's what we're looking for. We would say this is a survival benefit. If you get a lung transplant for a disease that has a terrible prognosis, we can help you with a lung transplant. This is a slide in just focusing on the red line. These are all the clinical trials that have been done in ILD and IPF, and the number of patients that have been involved on the y-axis, and really just to highlight how the number of patients that have been involved in trials is one of the reasons that we're making breakthroughs in this terrible disease. And up to 8,000, and we're, I think, approaching even up to 10,000 patients overall. And it's without that selflessness on the patient's part, on the family's part, to be willing to be put into a placebo-controlled trial, compare a treatment versus nothing, which is really the only way we can say if something actually works or not. It's a tremendous thing, and that's the reason that we've learned so much because of the patients volunteering. So the way we used to treat IPF for decades changed in 2011. When we found out we did a trial comparing the standard treatment, which is prednisone, azathioprine, and N-acetylcysteine, and we compared it to doing nothing, and we found out actually that more people had side effects, more people went to the hospital, and more people died with the way we were treating people. This is one of the landmark studies for us in the field, because it told us what we thought was the right thing to do was actually harmful to our patients. So we finally stopped after this trial, stopped hurting our patients. That was a major step forward for the field. And this should also remind all of us that with all the clinical trials and studies you hear on the news, breakthroughs, you have to be careful with one study or a small study because that one study may not be the truth. And I wish the news would stop reporting on small studies or very preliminary data. All it's going to do is actually going to end up confusing everybody. And trust me, I'm confused when I hear all about the heart studies and should I take fish oil or not, or should I, what should I do? We need to be a little bit more cautious before we just jump and say, this is the way we should do it. And this study for IPF showed us that what we were doing was not only wrong, it was hurting people. Pirfenidone, it's a new treatment. It's an anti-fibrotic. So as opposed to anti-inflammation, it's an anti-fibrotic drug. And these lines basically show a person's lung function over time, over 1 year. In the gray is the placebo arm. In the other color, which looks kind of more gray-blue, was a pirfenidone arm. It lessened the rate of your decline of your lung function. But as you can see, it doesn't stop it. So this is what happens with IPF, is in this gray area. This IPF, the patients decline, and in the other color, we slow it down, but we don't stop it. We also have another drug called nintedanib. It's also called Ofev on the brand name. It also reduced the decline of your lung function. So 2 treatments are FDA approved in 2014 for IPF to slow down the disease, but again, not stop or reverse it. It's still an irreversible lung disease. So these, I think, I look at, again, I'm an optimistic guy. Pirfenidone is a stepping stone, nintedanib a stone, but we still have a long way to go, and ultimately, this is the goal we all have, is to try to cure this terrible disease. And how to get there, we need research. That's one of the reasons we got these 2 stones up here, a couple steps. More research is needed. At San Antonio, we're actually part of, these are a slide of showing the phase 2 trials right now. We're part of this trial, and soon we'll be starting another trial. So we have clinical trials available to keep moving getting to the next stones, keep going toward a cure, keep trying to advance our knowledge and treatment of this disease. So essential interventions for any chronic lung disease. Quit smoking. Life is beautiful. I had to put that as a positive note to it. But you have to quit smoking. There's no way around it. If I could put another picture in there, as you can see, I like pictures. I'd put a tailpipe of a car with exhaust fume. And if you like smoking, might as well be doing that, because that's basically what you're breathing in, is carbon monoxide, and probably in smoking might even be worse than that, because that might be pure carbon monoxide and exhaust. The smoking has carcinogens and other things that it's inevitable you're going to get cancer. Just quit smoking or don't smoke, period. That's my pulmonology advice. Supplemental oxygen. So if you need it, you have to have oxygen to breathe. And so too little oxygen, not good. Too much oxygen actually can also be harmful. But if you need oxygen, you need to have it. And she looks like she's enjoying and is happier with oxygen on. And exercise. So these are things that patients can do. If you have any kind of lung disease or heart disease, if you exercise, what I tell patients is it'll help keep your heart stronger, and one of the most important things, keeps your muscles stronger. There's no pill for that. It doesn't happen overnight. It's exercise. You have to keep, as mom says, use it or lose it. So you have to be active. And I think, in this today, that was a big focus of the conference today, is how do you be active? I missed the Wii session, but anything you can do to be active. I don't know if there was the dance revolution or the different games. I mean, whatever you can do, be active. Immunizations. So top public health interventions that save the most lives in the world: clean drinking water, which we don't have to worry about as much, here in the United States, fortunately. as opposed to other third world countries. But preventative vaccinations, lots of talk, of course, about vaccines. And I know there's a lot of controversy, and I'm not gonna get into it. I don't want to turn off anybody if I mention or say anything too much about it. But for the lung, flu shot every year has to happen. Pneumonia shots, we have 2 pneumonia shots now that you have to talk to your doctor about. And immunizations are for everyone, from a little infant all the way to our older folks. And love them, protect them, immunize them. So join a support group. With all the different diseases, there are probably support groups out there, but I know as a fact, more rare diseases, less common diseases, you need support, because you can feel very quickly, if you have a rare disease, you can feel like you're the only one that has it. And it can be very scary. It can be very, very scary. But the beauty of the internet now, in addition to all the other things, like getting pictures, is to look for support groups, get information, Pulmonary Fibrosis Foundation, and even online support groups. I have a number of patients of mine who interact virtually because they can't attend a support group, so they're on virtual support groups. And they're talking to other patients, what are you going through? Have you done this? Have you done that? What works for you? And I think it's wonderful. It's empowering to take charge as opposed to, and be proactive rather than just reactive. And so I'm part of the San Antonio Pulmonary Fibrosis Support Group. We've held free clinics to try to get people diagnosed and encourage them and get them on the right track. And Dot De La Rosa right here is a former lung transplant patient who founded the group because she felt that she didn't get a lot of support when she was going through this. She wanted to give back, and she started the group and is our, as I call her, our fearless director. So at San Antonio, I started a free, ILD clinic. I wish it was free, but they wouldn't let me run it for free. But June 2011, and I started the ILD program in San Antonio in 2012. We were part of the trials that showed that one drug, pirfenidone. That was a study called the ASCEND trial we were part of. And also I have that multidisciplinary conference, which next time I will have an actual picture of my group here. But this is another Google grabbed picture showing a multidisciplinary conference here, and a community outreach, which I think these are all really the elements that are needed to really treat the patients the best and give them the best support possible. So to conclude, the key points that I really wanted to just drive home. At this time, everyone's kind of shuffling their stuff together, but no, I don't hear that, which is pretty nice. Maybe people expecting me to go for longer, but maybe everyone's happy that, hey, this is wrapping up. Symptoms of ILD, such as unexplained shortness of breath or chronic cough, may be misdiagnosed as COPD or heart disease. And that's something that the docs are going to think about those first. Statistically, they're more common, but there's other things that can actually be more serious. As early as possible, I'd recommend that if you have a diagnosis or suspicion of somebody has interstitial lung disease, to get first referred to a community pulmonologist, and then subsequently referred on to an ILD center of excellence if necessary. And diagnosis and treatment can be very challenging. It can be extremely difficult, especially when you see in your community practice here or anywhere, 90% of patients are going to have asthma or COPD. 10% or less maybe might have ILD or some other lung disease. So you just don't see it commonly. And when you don't see something commonly, you don't recognize things as quickly. And that's why patients oftentimes get delayed in the diagnosis and the referral happens late. An earlier diagnosis, a more accurate diagnosis, the sooner you're evaluated as center of excellence, I think, and there's actually data that shows outcomes are going to be better. And that means, to me, bottom line, better breathing equals better living. And my final request and call to action is that we're still far from a cure. I showed those stepping stones, but we have a long way to go. And I'm still pretty early in my career. I've been here for 5 years, and so I'm planning to go do this for a long time, I hope. For any disease, and this is where I want to just make it more general. Any disease, especially for ones that we don't have good, safe, and effective treatments, strongly recommend, think about, and consider enrolling in a clinical trial at a center near you. Ask your doctor about it. You can also visit a website where all the big trials that we do in everything in medicine is on clinicaltrials.gov. It has to be registered there. Think about joining and participating in a clinical trial. And I won't get into the details. I can talk to you afterward about what I think are the benefits. And I can tell you that almost every patient of mine who's been part of a trial, even if on the placebo arm, has gotten a benefit from it. I think a lot of it has to do up here. You're proactive. You're doing what you can. You're fighting the disease. Even if the treatment in the trial may not necessarily help me, it's amazing how selfless nearly everybody is, that they want to help other people. They want to help us learn more, and they hopefully will lead to better treatments in the future. So I want to acknowledge the division at UT, for which I would not have been able to do any of this without, and my research team, the team at my clinic, my wife and son, 7-month-old at home, Ajay, who gives me that smile when I get home. There's nothing like that in the world. And so just want to thank you all for your attention. I really appreciate it and the opportunity. And I'm just going to leave this slide up at the top that if you know anyone who has interstitial lung disease or pulmonary fibrosis, please don't hesitate to call my clinic at that number or email me, and we will do everything I can and we can to have the patient seen, evaluated, and obviously we'll have to create a good collaborative effort with the local doctors, but being seen at the Center of Excellence is a big step in the right direction.
Thank you, Doctor. Very informative, and we were going to be getting a lot of questions from the audience, but as they get ready and start thinking about their questions, I have one for you in terms of interstitial lung disease before IPF. Has there been any evidence that anything like allergies could be a risk factor in doing more chronic interstitial markings? And if so, are there any recommendations of things that you could be doing to maybe prevent further problems or getting into the fibrosis?
Sure. No, great question. I think allergies, no one's been able to specifically link allergies to development of IPF or interstitial lung disease yet. Now that's not saying that it doesn't exist. It's just that we don't really have a lot of evidence of it right now. I just think that I know all my patients with lung disease, the sinuses, your sinuses, are directly linked to the lungs. There's a direct connection, and we lose sight of that. And also the esophagus and reflux has a chance. So I think all of those different things going on need to be addressed, especially if someone has symptoms. Once we can get more definitive information that there's truly a link, then we start to look at how can we prevent it more. But right now, no one has shown any evidence that screening for it or trying to diagnose it early has shown any benefit. I think for sure symptoms are there. It's not going to help you breathe better if you have bad allergies. I mean, that's where you have to see an allergist, and you want to get checked out, and you want to make sure that there's no, that's not an ongoing issue, because it's only going to make things harder for the breathing to happen. And so as far as treatment goes, again, nothing specifically for allergies. That's where I would actually recommend to my patients seeing a specialist at that point to get get that issue optimized.
Thank you.
Great. Any other questions or comments? Yes?
I have shortness of breath, I have biopsy, and I have had the granuloma. I've been diagnosed with that granuloma, but I don't know if that's the same thing as ILD or what.
Yeah.
I haven't been diagnosed with that. I recently did a breathing test, and the first test I did came out fine, but I have nodules in my lungs. Lots of nodules. Is that the same thing?
So I don't want to get too far into specifics in your case, especially in this in the big group, but we can talk about the specifics later if you like. When you mentioned granulomas, granulomas basically means kind of it's a ball of some of our immune cells, like white blood cells, that kind of stick together, and they kind of create these balls. And those balls can be microscopic, and they can grow to be even larger, and they can be in the lung tissue, they can be in the lymph nodes, they can be in a lot of different places. And there's a number of different, we call it granulomatous diseases. Things like sarcoidosis is a granulomatous disease. Fungal infections can actually cause granulomas. Other types of infections can cause granulomas. So it's a very large family of different diseases when granulomas are present. In pulmonary fibrosis and interstitial lung disease, there's a couple of interstitial lung diseases that granulomas are a component of, but it's usually not the primary component. And so there's a chance always that granulomas, when you find it, can develop interstitial lung disease, but it's not always the case.
I'm taking omeprazole for gastric reflux, but I don't have any symptoms. I don't have any symptoms at all, but when I don't take it, I can't breathe.
So I think that's, you bring up an excellent point, which is that in interstitial lung disease and pulmonary fibrosis, up to 3 in 4 patients, 75%, actually end up having clear evidence of reflux disease. Of those people, only 1 in 2, or half of those people, actually have symptoms. So 50% of the time, you actually may not actually have symptoms of reflux. If you have lung disease, it's very important to consider looking for whether or not the reflux is there, or just treating it, because it can be a significant component, and we don't know yet why some people don't have symptoms. But that's kind of a scary thing for me to think about, that half of people don't have those symptoms. We commonly think about heartburn, acidy taste in your mouth, symptoms especially coming on after you eat, and so reflux, I think, is a big thing that we're looking at. We still don't know for sure how best to treat it. Actually, there's studies looking at for patients with IPF whether or not just medicine is okay, or even do you need surgery sometimes to fix the reflux. But obviously, when we talk about surgery, we talk about more risk to it. So we have to really be careful, get the right data that we need. But it's important to think about reflux as a contributor to cough, just cough itself, shortness of breath. Reflux is something that we talked about, allergies and reflux, and obviously the lung itself, but all of these things are happening right here, and they can impact how you breathe, and they can impact your quality of life. Yes, sir.
Thank you. I'm looking for coming to Laredo. My question is general. Basically, by looking at the charts over the 20-year period, we see an increase of surgeries and diagnosis of LD, and COPD. And that's obviously connected to environmental issues, not only at home or at work, regular environmental. We see that every time we turn the TV on, we see cities out here in other countries and close to ours that are polluted, and multitudes of people walking around with masks on. Is that truly a preventive measure for people that reside in those cities that are so polluted, contaminated that they're actually shutting down factories and car travel for weekends and days on to save their own population, basically? Is there any preventive for multitudes of populations in those cases?
Another excellent question. I think it primarily is related to, is there any way to prevent kind of environmental exposures to cause lung disease? So far, we have not found a single type of preventative way. I think wearing a mask makes sense, especially when you're exposed to, you're exposed to pollution and other kind of things that can only hurt your lungs. The problem, though, is that a mask, we have to balance it out with does it work or not, and B, how are you supposed to? What kind of quality of life you're going to have wearing a tight-fitting mask and going out and about? If you're in Beijing, not to pick on Beijing, but the way you're talking about I don't know if people have seen pictures of Beijing at some times where it's unbelievable the amount of pollution that they have with all the cars and trucks and buses, etc. It's almost like it's basically smog that's created. If I'm in an environment like that, the common sense thing would be to wear a mask when you're out breathing stuff like that. However, there's really no data that says that works. We don't actually know for sure if that works. It makes sense, but the reason we don't have data to say it works, and it may not work completely, is that a loose-fitting mask, really will only probably block out some of the big things, particles. The problem that a lot of us are facing is the invisible stuff that we're breathing in, the microscopic particles. Allergens and pollens are microscopic, other things that are microscopic. In order to block those out completely, you'd have to wear a really tight-fitting mask, which is designed to block out those small particles. It's really just not yet feasible to do everywhere or anywhere. I think what I tell my patients who develop lung disease is anytime you're around someone who's sick, or you're around something that you know is like smoke or other kind of potentially toxic kind of fumes, you have to wear a mask, or ideally don't go around that. Avoid that at all costs. That's the best way to prevent it. But otherwise, just try to wear a mask to try to protect yourself, but it's still not foolproof. And I think that's something, hopefully more regulations. I think the answer to your question really is we have to do a better job of not polluting our environment, as opposed to being more reactive and wearing a mask. We have to get to the root cause, stop polluting the environment, and make our, that will ultimately help, I think, our society breathe better and live better. Question back?
My question is, can ILD be related to our autoimmune system? Autoimmune system, like any other diseases that, like rheumatoid arthritis, that the autoimmune system attacks, rather than our immunity?
Absolutely. So actually, one of the more common causes of ILD is autoimmune diseases. Rheumatoid arthritis and scleroderma, I mentioned a few, but there's a number of autoimmune diseases. And the key there is anytime you have a lung problem, and you also have joint swelling, muscle pain, other kind of rashes, you want to get to a rheumatologist, an expert when it comes to autoimmune disease, because like I said before, I think IPF oftentimes gets misdiagnosed because we're just not looking sometimes hard enough to find a cause. And I've had a number of patients been told they have IPF until we look harder and we find there's actually autoimmune disease that was the culprit. And then we can initiate more targeted therapy that has actually some good evidence that it can help. There's a question?
Yeah. Sir, patients that have childhood patients that have like childhood asthma to adult asthma, are they more likely to have or develop ILD? And would they be patients that would benefit from being referred to ILD center?
So you said what, patients who have asthma?
From childhood, and then they progress and they keep, being asthmatic as adults. Are they higher risk for ILD?
So we don't think they are higher risk. We haven't actually shown that asthma itself can lead to ILD. Asthma can lead over time, if not treated or taken care of appropriately, can lead to more chronic asthma, which still leads, goes into the category of obstructive lung diseases as opposed to restrictive lung diseases, which is ILD and IPF. But obstructive lung diseases, it can be more chronic, in which case then sometimes it's more resistant to different treatments like inhalers and things. But no real data to say that it can lead directly to ILD and IPF. But again, like I always say, just because we don't have that information doesn't mean that it doesn't exist. I think so far we haven't yet seen that. Okay.
How important is it to have your immune system to maintain your immune system?
How important is the immune system to maintain?
In order not to have these issues about the lungs.
Yeah. So, I mean, extremely important. There's no way around it. And the thing with the immune system is, the way to think about it is our home security system. It's our anti-burglary system. It's to protect us from things that we're exposed to in our environment. And just to give you an analogy, I have a 7-month-old at home. My wife, rightfully so, we're both very protective of him. We're first-time parents, so we didn't take him outside, I think, for the first 6 months in terms of seeing anybody. And I think I had some friends of mine who questioned whether or not I grabbed a picture of a kid, and that's what my kid is, but that he wasn't real because they hadn't seen him. But the immune system works the best, and especially early on, it has to be exposed to the environment. So we're now bringing him outside, and so he's getting exposed to more people. Because I think his immune system's strong enough that I'm not worried that he's going to get sick from it. But that's the only way, like everything. I talk about exercise to help our muscles. The immune system needs exercise to get stronger. You have to expose yourself to a lot of different things. The goal is don't expose yourself to too much of whatever it is that could hurt you. If it's a small amount, it can actually probably strengthen. Immune systems can be very active. Talked about granulomas before. That's a hyperimmune system. It can also be suppressed. Oftentimes by different diseases can suppress it, or medications can suppress it, where now you're at an increased risk for infection. So always want to try to keep the immune system strong and in balance. How do you do that? A well-balanced diet, fruits and vegetables, antioxidants to help kind of keep the inflammation down in your body, and exercise to help keep your overall physically fit. But I think we were talking about earlier, you have to also, I think, mental part has to be there too, mentally strong, which then will help support your immune system, and vice versa. The immune system was going to help maintain your mental strength. Great question.
Okay,
Here you are.
okay. You mentioned that cigarettes are one of the causes. Do e-cigarettes cause the same damage as the regular cigarettes?
So excellent, very hot topic right now. That's something that you're seeing on television and movies. People are lighting up their e-cigarettes now instead of regular cigarettes because that's bad now. Everyone that has a bad rap, but e-cigarettes, how bad can it be? Actually, e-cigarettes, it's interesting because there's debate as whether or not there's benefit to it. I have some patients who are trying to quit smoking, and they're coming now in to see me with an e-cigarette. And my first question to them is, are you still smoking too? And if they are, then I said, well, you need to first quit regular smoking, cigarette smoking, first and foremost. But if they haven't quit they have quit cigarette smoking, just smoking e-cigarettes, it's actually probably lesser of the two evils if you compare the two. But the problem is that e-cigarettes, you're inhaling something, it's a vapor. It has nicotine in the vapor, but also it's an unstandardized industry. Every company will put whatever they want into that vapor. Chemicals, formaldehyde has been shown in some studies to be at high concentrations in that vapor. I hope, if anything, if you got anything from my talk, hopefully one of the things is that everything and anything we breathe into our lung has a potential to cause injury. So then you have to kind of wonder, I have to wonder, do I want to take a chance and trust? I mean, we put a lot of trust for many, many years in the tobacco industry because they told us it didn't cause cancer. I would be very hesitant about putting a lot of trust in these random companies, who knows where they are, offshore or onshore, who are selling these e-cigarettes. Personally, if you don't smoke, I wouldn't try it because actually they've shown for kids and younger adults that leads to them going to cigarette smoking. So I wouldn't do it if you don't smoke. If you do smoke and you've tried your best to quit, because it is extremely difficult of how addictive it is, e-cigarettes may be an option for you, but you have to talk to your doctors about it so you have the right guidance. But I think you are taking a chance using e-cigarettes in general because they can itself cause different lung diseases, and interstitial lung disease also. There's more data that it can be a contributor to development of interstitial lung disease too.
Yes, sir.
Yes, sir.
In your opinion, how important is to breastfeed for newborns to develop a good, healthy immune system?
So if you ask me that question,
Yes, I
before 7 months ago, I would have told you I'm a lung specialist and I deal only with the lungs, and I'm actually specialized primarily in interstitial lung disease. But I have, I know how important, having read the books around the time, first time parent, extremely important for breastfeeding. I don't know off the top of my head the data behind it, but I know that the immune systems of the babies are only going to be stronger and protected, especially in that early time. That's like a crucial time that you don't want to get sick. That's a great time for the babies to get the antibodies and the immune system for mom, and highly, highly recommended in everybody if possible. So that's the only time so far I've ever been asked about that. But I think I've said 7 months under my belt as the father I think I can wing it.
Mine is a two-part question. First of all, when you have an autoimmune problem, what comes first, the lung or the autoimmune, or is it, you don't know?
Safe answer is you don't know. However, most of the time, it's the autoimmune disease, like your joints and those symptoms start up first. But there is actually a number of patients, and even in some different autoimmune diseases can do different things. But in some of the diseases, maybe even 30% or higher, you can get lung disease first, and then you develop the autoimmune disease. That's why it's often unrecognized, because a lot of docs who don't do ILD and IPF like I do on a daily basis kind of can forget about that or not know that. And so we don't look to see what the cause is, because we don't anticipate they're going to have an autoimmune disease because they don't have symptoms of autoimmune disease until we search for it, and then we find something. So it's not the majority, but there are some patients that can develop lung disease first, like interstitial lung disease, and then they develop autoimmune disease later.
Next question. Okay, you have a baby now. In your home, do you have carpeting?
We have a couple of rooms that have carpeting.
You're not afraid of that?
So I am not afraid of it, but I'm getting more afraid of it now that you make me think about it. I think you're talking about kind of more allergies and those things. I think it's a very valid point. I think really, the key is just trying to maintain as clean a home environment as possible, and kind of just maintaining and regular kind of vacuuming and things. I'd have to ask.
Short carpet that has
short carpet and
maintain clean. And if you put the baby on it, then you put the sheet over it so that it will be safe.
I just learned something. Thank you all very much. Appreciate it.